Good morning, myself, Dr. Somir Boshak. Welcome you all in the knee pain web series. This is the part 2 about knee osteoarthritis and role of newer treatment like platelet-rich plasma and cold radiofrequency ablation. In previous topic, we have discussed what is knee osteoarthritis. Today, we will discuss how to diagnose it. This condition knee osteoarthritis is one of the most debilitating condition that's limit day-to-day life of the elderly population. So how to diagnose this condition? Diagnosis mainly based on the three symptoms. This is the decreased function, stiff knee and constant knee pain, and three sign, limited movement, crepitus and bony enlargement. Pain is the most important sign. Worsening, it is worsen with the weight bearing activity and improve with the rest. Ultimate last stage is the joint failure when patient unable to move his or her limb. How to diagnose this is the X-ray, X-ray and X-ray. This is the gold standard. If we do AP and lateral view, then we can see few changes like joint space narrowing, osteophyte formation, subchondral cyst, joint destruction. Ultrasound and MRI mainly to rule out other condition rather than to diagnose the condition. This is the X-ray and assessment done on the base of X-ray findings. Kellgren-Lorentz grading system show us that in grade 1 there is doubtful narrowing of the joint space, and in joint space here is possible joint space narrowing and possible osteophyte. This is stage 2 where definitive osteophyte and possible joint space narrowing. This is stage 3 where multiple osteophyte and definitive joint space narrowing. In stage 4, there is multiple osteophyte, definitive joint space narrowing, also bony deformity, sclerosis, all this happens. What is the aim of treatment is to decrease the pain, improve the or preserve the mobility and reduce the disability to improve function of that particular joint so that patient is not getting bedridden. What are the treatment options in our hand till date? This is the non-pharmacological modality. This is short-term reduction of pain, physical activity, exercise, exercise and exercise. With exercise, there is more generation of the synovial fluid and joint mobility will be restored. Muscle strengthening, range of motion exercise, all are very important. Weight loss is another important thing for the overweight and obese patient. All these are non-pharmacological modality, and physiotherapists, there are important role regarding therapeutic ultrasound. These are few exercises which I get from internet. These are few important exercises for day-to-day activity. There is also link related to this exercise by Andrea Furlan. I recommend this to my patients also to do some activity from learn from the physiotherapist or by watching my channel. And these are my recommendation for Andrea Furlan regarding knee exercise for the knee osteoarthritis. She recommended few weight based exercise. All are you can go through this video and in spare time. Okay, Next come to the pharmacological therapy. These are the analgesic anti-inflammatory agent. Paracetamol initially short term first line treatment for symptomatic osteoarthritis. Next come NSAID. We know this is diclofenac gel, diclofenac tablet, ibuprofen, and next come to the celecoxib, etirocoxib. All these are NSAID. Few are selective, few are non-selective, but all this associated with few complication. Like with NSAID, there are gastric ulcer. With COX-2 selective inhibitor, there are stroke, cardiovascular complication like celecoxib, etirocoxib. So be cautious about using NSAID medication. Next come few medications like opioid related and opioid like medicine like tramadol, tapentadol. Those who are not responded to the paracetamol and NSAID, we can recommend this, but we have to be judicious regarding the use because they have not also not free of complications. Next come the duloxetine, selective serotonin reactive inhibitor. These are co-analgesics. Next is intervention treatment. Intra-articular injection for short-term improvement of the symptoms and pain, function. Mainly are hyaluronic acid injection, corticosteroid injection, and platelet-rich plasma injection. These non-surgical treatment have important role in elderly population where there is chance of revision TKR we can avoid and joint revision risk we can avoid. With this medical comorbid patient, we can apply every type of patient we can initially apply these treatments. But regarding surgical treatment, it is the only option left for the end stage disease. So this is the last resort when there is no other option remains. It is the treatment then applied. Regarding the different intervention in particular, there are few recommendations and I'll go through the latest guideline. Regarding this guideline, I'll going through these recommendations. A review of current injectable therapy in published 2020 in Pain Research and Management. They recommend already few society also recommend few treatment. I'll go this oral NSAID like arthritis group recommend inconclusive evidence about the PRP hyaluronic acid stem cell. Americans Academy Orthopedic Surgeon also recommend oral treatment tramadol this. And regarding inconclusive evidence about corticosteroid PRP chondroitin sulfate tablet. Osteoarthritis Research Society also recommend oral NSAID, paracetamol, SNRI. There are inconclusive evidence regarding chondroitin, glucosamine, hyaluronic acid, opioids. American College of Rheumatology recently recommended intraarticular steroid, tramadol, NSAID, and inconclusive evidence hyaluronic acid, tramadol, SNRI. But what we came to know about this intraarticular steroid that it is effective for short and medium term treatment, and there is chances of chondrotoxicity, cartilage damage, and accelerated degeneration of the disease, osteoarthritis progression. These are evidence-based side effect. So I personally, in our society also personally, not recommend intraarticular corticosteroid injection. Intraarticular hyaluronic acid injection, it is FDA approved in 1997. In 2020, American College of Rheumatology also approved. There are few different molecular weight, low, intermediate, high. Generally speaking, we in our hospital we use Synvisc 1. This is the high molecular weight, one injection. Monovisc This is also medium low molecular weight single injection. These are few example. There is the benefit of hyaluronic acid. It is maximum effect at persist 8 to 24 weeks from the time of injection, and refractory patient we can use this treatment intra-articular hyaluronic acid injection. Side effect is minimum, pain or swelling, serious adverse effects rare. It is a sequel therapy, intra-articular hyaluronic acid injection, but hyaluronic acid only act as a lubrication, nothing else. Visco supplement is own niche in early osteoarthritis, use effective for stage 1 and stage 2 arthritis, but with evolving time, emphasis should be given on the chronic disease, lifestyle modification, symptom management to regeneration treatment and repair of that particular site. So feel free to contact us any chronic pain, osteoarthritis pain related symptom. Okay, bye bye.